and perform a physical examination in order to reach a diagnosis. Now, again, the reinforcement of the various problems. The incontinence is an involuntary leakage of the urine. Then stress incontinence, involuntary leakage of the urine with an effort. Urgency is involuntary loss with urgency. Mixed incontinence, it is a mixture of urgency plus SUI. Continuous urinary incontinence is the continuous dribbling of the urine. Then frequency is number of voids per day from the waking up in the morning till she sleeps at night. Increased daytime urinary frequency is increased micturition during waking hours of more than 7 per day. Nocturia is interruption of the sleep one or more times because of the need to micturate, and overactive bladder syndrome is urinary urgency along with frequency and nocturia with or without urge urinary incontinence in the absence of UTI and other pathology. Now coming to the history taking, the duration of the time with urine loss, associated symptoms and the severity should be asked from the patient. Urine loss with activities like coughing, jumping, sneezing means it indicates the stress incontinence. Symptoms preceded by an urgency episode indicate an urgency incontinence. Then we should always take the history of UTI, previous surgical history. Some surgeries lead to SUI and some surgery lead to incontinence, urge incontinence. Then age of the patient is very important because the stress urinary incontinence usually occurs in the later decades of the life, that is the fifth decade. Older age group have the mixed type of symptoms. Then after vaginal delivery, it is usually a stress urinary incontinence. Pregnancy also disposed to the stress urinary incontinence, and high parity, it should be taken into account because it also leads to the stress urinary incontinence. Similarly, obesity, because obesity leads to the levator aniaprophy and which predisposes to the new onset of stress urinary incontinence. Then a disease which diabetes which causes diuresis and neurovascular injury, and it leads to the detrusor overactivity. Similarly, the history of cough should be asked, history of smoking. Then functional causes for incontinence, maybe there is a mnemonic, that is diapers. Then UTI. Diapers is delirium, infection, atrophic urethritis, vaginitis, pharmacological causes, psychological causes, excessive urine production, restricted mobility, and stool impaction. Then the drugs, like we should take always the history of the drug intake. Benzodiazepine, that leads to the diuresis. Alcohol, similarly diuresis. Anticholinergic, alpha agonists, beta blockers, calcium channel blockers, and ACE inhibitors. Then coming to the physical examination. So we should always do a general physical examination. The mental and cognitive functions of the lady should be assessed because it may lead to the urgency, frequency, and anuresis. Then the neurological functions should be assessed, and history regarding the Parkinson's, multiple sclerosis should be taken, which leads to urge incontinence. Then the cardiovascular system should be taken into account because, as madam has said yesterday, it leads to the nocturnal micturation, nocturia, because of the fluid going to the bladder at night. Then pulmonary functions should be assessed. COPD especially leads to the stress urinary incontinence. Then again, the nutritional status of the lady, obesity, mobility, and the gait should be assessed. Then coming to the pelvic examination, the goal is to investigate pelvic support defects. Then examination should be done in the lithotomy position. It can be done in upright or the standing position also. Evaluation of the vulva, vagina for the atrophy, vaginitis, and dermatosis should be done. Inspection or palpation of the urethra may reveal the tenderness or the mass in case of infection or a diverticulum, as madam has already mentioned. If there is pelvic organ prolapse, the staging should be performed. Integrity of the pelvic floors and liberator ani muscles should be assessed. The method is with the 2 fingers in the vagina, the patient is asked to contract the muscles used to hold the urine or to avoid passing gas. The ability to contract and strengthen the duration of the contraction are all measured. Then bimanual rectovaginal examination should be done. Then a test which is obsolete now, that is a Q-tip test. It is done to assess the motility of the urethra. So introducing a cotton-tipped swab into the urethra and asking the patient to do a Valsalva maneuver to measure the angle of the deviation of the urethra. More than 30 degrees deviation is consistent with the hypermotility of the urethra. Minimal or no deviation suggests SUI, stress urinary incontinence. But this test is not routinely done. Cough stress test is done either with a full bladder or an empty bladder. The advantage of doing it with the full bladder is that it is easier to demonstrate the urine loss from the urethra in a woman with SUI. If the history is suggestive, patient is asked to stand up and possibly jump or cough vigorously while the examiner observes the urine. A positive empty bladder test indicates SUI and intrinsic sphincter deficiency. Then a test which is very easy, that is done by the ultrasonography, the post-void urine, and the post-void residual urine volume is amount of urine in the bladder within 10 minutes from the voiding. And if it is more than 150 ml, it is abnormal. Then simple bladder test is the bladder diary. The patient is asked to measure the day and night urine volume, look for 24 hours total urine output, number of voids per day, average voided urine, and bladder capacity. The patient also documents the time a urine loss occurs and whether associated with a stress activity like cough, sneezing, cough, or with urgency. Then last but not the least, the urine analysis to be done to rule out the UTI. Then the pad test, patient is asked to wear incontinence pads before and after taking the medication to determine if the drug results in a decrease in volume and frequency of the incontinent episodes. Pad test detects the presence of urinary incontinence that is not demonstrable even with a full bladder. Now coming to the pelvic organ prolapse. It is the progressive herniation of the pelvic organs through the urogenital diaphragm. Then pelvic supports are the common pelvic supports disorders are the rectocele, which is a posterior defect, the cystocele anterior, antrocele posterior, and the uterine prolapse. A rectocele is a protrusion of rectum into the vagina lumen resulting from the weakness in the muscle wall of the rectum and the paravaginal fibromuscular connective tissue which holds the rectum in place posteriorly. An antrocele is a herniation of the peritoneum and the small bowel and is the only true hernia among the pelvic support disorders. A cystocele is a descent of the urinary bladder with the anterovaginal wall. These are the pictures which is showing the normal. Here is the cystocele and the rectocele. This is the complete prolapse. Then the risk factors for the prolapse are increasing age, frequent vaginal deliveries and more vaginal deliveries, then the increased parity, constipation, obesity, and chronic obstructive pulmonary disease. Other risk factors are history of hysterectomy, obesity, previous prolapse operations, and the race. Symptoms. As ma'am has already covered in detail, then there can be voiding dysfunctions, including urinary incontinence, obstructive voiding symptoms, urinary urgency, frequency, at the extreme, urinary retention, and upper renal compromise with resultant pain or anuria. Other symptoms often associated with pelvic organ prolapse include pelvic pain, defecatory problems like constipation, diarrhea, tenesmus, fecal incontinence, back and flank pain, overall pelvic discomfort, and dyspareunia. Physical examination is divided into compartments. The anterior and the posterior compartments are best examined with the Sims speculum. It is a very simple speculum. It is bivalve. The speculum is placed posteriorly to retract the posterior wall downwards when examining the anterior compartment and placed anteriorly to retract the anterior wall upwards when examining the posterior compartment. A rectovaginal examination is also done. During the evaluation of each compartment, the patient is encouraged to perform a Valsalva maneuver so that the full extent of the prolapse can be ascertained. It may be helpful to perform a standing straining examination with the bladder empty. This is for postgraduates. Now, POPQ examination provides a standardized measurement system to allow the more accurate assessments of the post-operative outcome and to ensure uniform, reliable, and site-specific descriptions. This is a reinforcement of yesterday's lecture. Madam has simplified, but the standard thing is there are three things with the genital hiatus, that is GH. Okay? Perineal body and the total vaginal length, which will be coming.
ये सुनो, ये बना रखा है, रुको रुको, ये बनाया था कल, ये बना के रखा था इसलिए.
So it is the anterior part, this is the posterior part, and these are the landmarks in the middle. That is the genital hiatus, the perineal body, and the total vaginal length. This is the anterior part, which has got 3 points, A, B, and C. Anterior will be AA, BA, and C. Okay? A, B, and C points. तो anterior के लिए हमें क्या करना है? A for anterior, AA and BA. फिर posterior में हमारा same है, A, B, and D points. Okay? Here it will be AP and BP. Okay? So these are the landmarks and these are the points, 6 points. 3 landmarks and 6 points. Now you can see in the picture, this AA point is a fixed point which is -3 at the -3 level. Similarly, the AP point is a fixed point which is at the level of -3. Then BA point is a movable point and it can extend to the TVL. Okay? Similarly, the BP point is also a mobile point which can extend to the total vaginal length. This is a C point, which is the lowermost part of the cervix, and D point is there, which is the fornix, posterior fornix, and it is not there if the wall prolapse is there, if it is a vaginal hysterectomized patient. This is the genital hiatus, this is the perineal body, and this is the total vaginal length that is denoted by the TVL. Okay? So anything which is in minus is no prolapse. Anything, as ma'am has already showed yesterday, anything in a positive is prolapse. Like BA, this will be cystocele. C, this will be rectocele. BP is the rectocele and TVL here is 8. So anything in the positive will be prolapse, negative won't be a prolapse. Then the pelvic muscle function assessment can be done by a bimanual examination with the patient in the lithotomy position. The examiner can palpate the puborectalis, pubococcygeus muscle inside the hymen along the pelvic side walls at approximately 4 and 8 o'clock positions. Check for the basal tone, muscle tone, whether there is increased with contraction as well as strength, duration, and symmetry of the contraction. A rectovaginal examination should also be performed to assess the basal and contraction muscle of the tone of the anal sphincter. These are the stages of the prolapse: 0, 1, 2, 3, and 4. And this is a picture denoting the 0 is no prolapse, 1, 2, 3, and 4. Similarly, here, stage 0, stage 1, it has come down, stage 2, stage 3, and stage 4. Thank you.
Thank you so much, Shazia.